Okay, good evening, good morning, good afternoon to everyone. We'll get started. I know there's others still joining, but we'll just start with some introductory comments and then hand over to the three experts for the main event. Welcome and thanks for joining the first inaugural Common Sense Oncology Journal Club. My name's Chris Booth. I'm a medical oncologist in Kingston, Canada, based at Queen's University. I know nothing about leukemia. I forgot everything I learned in training. So I'm a GI medical oncologist, so I look forward to learning from our three experts and from the rest of the colleagues that have joined for the discussion today. I'm just going to provide a little bit of an overview for where we're going, and then I'll introduce our three speakers. Actually, I'll start with introductions. So we have three of the original founding leaders of the Common Sense Oncology movement, all of whom are experts in hematologic malignancies. We have Aaron Goodman, a hematologic oncologist from University of California at San Diego. We have Bernie Marini, a pharmacy clinical specialist in hematology from the University of Michigan. And we have Manju Sengar, a medical oncologist and department chair from Tata Memorial Center in Mumbai. So I'm going to hand over to them in a moment, but I'm just going to walk through a little bit of introduction about Common Sense Oncology. So some of you may know this initiative launched almost 1 year ago. And the idea today is we're going to walk you through a published paper in AML and talk about some of the principles of AML from the Common Sense Oncology perspective. But just to give you a little bit of background, this was our paper published in Lancet Oncology last summer, which really was kind of the official launch of this movement. It's been called the Common Sense Oncology Manifesto. And just to tell you a little bit about the ethos of this group, this is a broad-based collective of people from around the world who care deeply about cancer care systems and research. It's comprised of clinicians, academics, editors, patients, patient advocates, policymakers, and members of the public. And the group came together to focus on a few things, one of which is health equity and justice, access to those treatments which make a major difference. The mission of Common Sense Oncology is to ensure that cancer care focuses on the outcomes that matter to patients. And so this group is, in some ways, an advocacy group to advocate for broad access for those treatments that make a major difference in outcomes. But we're also a group that believes we can do better and we can improve the way cancer care is delivered around the world. And we're big proponents of randomized controlled trials and treatments which measurably improve outcomes for patients. But we're also going to be willing to challenge ourselves in our field to do better, to raise the bar, and to push beyond some of the smaller gains or perhaps marginal treatments which have major side effects and downsides for our patients and their families. So the vision of Common Sense Oncology is that patients have access to those treatments that provide meaningful improvements regardless of where they live. Next slide, please. The group is founded on a set of core principles, and I'll just go through them briefly here. We believe access to quality cancer care is a basic human right. We believe that cancer research and delivery of care should be driven by the needs of patients and society rather than the needs of corporations. Patients and public involvement is essential when making policy decisions. We think it's reasonable that when a patient walks into a cancer hospital, they should be able to expect that the treatments offered and delivered to them help them live longer and better lives. We believe at the end of the day, all of these decisions about what treatment is right for any individual patient should be based on truly informed shared decision making. Cancer treatments should be fairly priced for the benefit they offer in the context in which they are used. Equity and access to the treatments we already know works should be prioritized just as much as innovation and new technology. And finally, comprehensive patient-centered care involves much more than just cancer drugs. We need to advocate and ensure that all of our patients have access to the other core services of cancer, which improve the outcomes of our patients. Next slide. This collective group has three core pillars of work. And we're tackling how we generate evidence, how we interpret evidence, and how we communicate evidence. So the first bucket is generating evidence. We want to ensure that clinical trials use and report outcomes that matter. And we have a series of project teams tackling clinical trials and trying to improve them and make them even better for the next generation of patients. Evidence interpretation is an education bucket, and this is to foster critical thinking and skills in epidemiology and critical appraisal by oncologists. And evidence communication is how can we improve the way that doctors talk to patients about treatments and benefits, how our community talks to the public and policymakers about outcomes, and how ultimately we can drive things forward in a collective way, understanding the needs of patients. So the event tonight is our kickoff of the Journal Club. These are going to be regular events. This falls in the educational bucket. At this point, I'm very happy to hand over to my good friends and colleagues, Bernie, Aaron, and Manju. Aaron, over to you with your border collie in San Diego.
Welcome, everyone, and I appreciate everyone from all over the world who's joined. I know it's an early hour, I believe, in India and some other places. So we're going to bring back some common sense to AML. It sure needs some lately. We do a lot of good in AML, but some stuff's going on that I think we need to question and go through. So this is gonna be like a 5-10 minute primer on AML, just to bring us all up to speed, specifically on secondary AML. So secondary AML refers to really two things. One, either therapy related, so they got an alkylating agent or a topoisomerase inhibitor, and then they get acute myeloid leukemia. So classically, like a breast cancer patient who gets adjuvant, whatever they give breast cancer patient these days, and then goes on to develop acute myeloid leukemia. And then the other form of secondary AML is when they have a pre-existing hematologic disorder, like myelodysplastic syndromes or myeloproliferative neoplasms. So those are our secondary AMLs. They tend to occur in older adults. Next slide. These patients, unfortunately, don't do well. So it's good to see randomized clinical trials in this space, but the prognosis for secondary AML is rather dismal. One is because it's predominantly in older individuals. Older individuals do worse. And we see very complex, ugly karyotypes and mutations and cytogenetics in these patients. Next slide. Okay, so one little more thing on classification. So these patients, the new WHO 2022, so they defined it, if you have a known MDS or MPN prior to developing AML, then it's a no-brainer. Those patients have secondary AML. But a lot of patients show up to the clinic without a diagnosis of a pre-existing MDS or myeloproliferative neoplasm.
Take over. So we're talking about AML with myelodysplasia-related changes. The WHO has divided it into different categories in the past. The 2016 WHO divided patients into really 3 different categories. First was patients who had an antecedent hematologic disorder. The second were patients that had dysplasia in multiple cell lines. And then the third was patients that had myelodysplasia-related changes via cytogenetic abnormalities that were classic of MDS and other myeloproliferative neoplasms. However, that middle bucket, those patients with AML, MRC because of morphologic dysplasia, there were data that those patients didn't perform worse in terms of long-term outcomes, in terms of response rates. And so it really wasn't a good way to define secondary AML. And so in the 2022 WHO criteria, they removed that from the AML with myelodysplasia-related changes definition and added in myelodysplasia-related defining mutational changes that were classically found in MDS and MPN patients. And so we now define secondary AML on a more genetic basis rather than by morphology. However, the FDA approval for some of these agents is agnostic of what we call it. It's just secondary or AML with myelodysplasia-related changes. So it's important to look at the right criteria when we're talking about what is secondary AML and what is AML with myelodysplasia-related changes. Here are some of the cytogenetic abnormalities and defined mutations in the WHO criteria that would be diagnostic of AML with myelodysplasia-related changes. When we think about secondary AML by therapy related, we typically divide it into 2 different buckets. And this is what we like to teach our fellows. There's 2 really main kind of classes of therapy related AML. The first is due to either alkylating agents or radiation therapy. And this typically has a longer latency period of around 5 to 7 years. And it's typically associated with a monosomal karyotype, losses of chromosome 5, chromosome 7. In contrast, therapy-related AML, because of prior exposure to topoisomerase II inhibitors, which would be like anthracyclines or etoposide, drugs like that, these typically lead to a shorter latency period of around 1 to 2 years. And this is typically associated with KMT2A, or we used to call them MLL or 11q23 gene rearrangements.
So AML induction simplified, it's actually not hard. It's not rocket science. Even a colon cancer doctor like Dr. Booth can handle it. Basically, the first thing you ask yourself is, are these patients fit for intensive induction therapy? Intensive induction therapy, there's a few choices, but the main ones, if they are, then they get it, okay? And 7+3, so 3 days of an anthracycline and then 7 days of continuous cytarabine. And then the other choice now is Vyxeos, which we will go over in detail. One little caveat, if they happen to have this FLT3 mutation, which there's 2 flavors, ITD and TKD, we have a randomized study that shows an improvement in overall survival in that population when you add a FLT3 inhibitor. There's actually 2 different FLT3 inhibitors in that space. Now, I usually use midostaurin, okay? That's it. That's if they are if they're fit for induction, that's all you have to know for AML treatment for induction. Now, if they're not fit, it used to be single agent HMA, best supportive care, but a few years back, there was now a randomized study with venetoclax plus azacitidine, which was shown to have a superior response rate, duration of remission, and overall survival. And it is now the standard of care in those not fit for induction. And if they're really, really not fit for induction, then the standard of care is just single agent HMA or best supportive care. And then I know, Manju, anything different? I know India doesn't have something. Would it be a similar practice where you practice?
So absolutely, it's 7.3, then, you have 7.3 plus midostaurin. We do have now generics of midostaurin, and venetoclax is not yet available in India in terms of that it's not been approved by the regulators here. But we do try to get these drugs imported, and we use them in patients who are not fit for induction therapy, and that's where the ven and HMA-based combination come in place. And of course, if they are not fit, then in that case, it's only the single agent HMA or best supportive care, which is often the case because of the underlying infections with which these patients come in.
Aaron, Manju, are you telling us you can summarize AML treatment on one slide? You made it sound so complicated in the past.
No, well, if you go to MD Anderson, though,
it's easy. This is like FOLFOX.
This is it. This is really it. I mean, there's some nuances to delivering the therapies, but this is really it. In a nutshell of newly diagnosed AML. I left out a little drug called gemtuzumab, but that drug's largely BS also, so we won't go there. But that's induction therapy. So next slide. Okay, I include this just because determining fitness, and this is related to other studies that look at those not deemed fit for intensive induction therapy. It's really hard to, that's like the hardest decision I think we make as AML docs. Are they fit for induction or not? And there's scoring systems. Here's the MD Anderson scoring system, and you can see all the points you get for being old, having a bad liver, creatinine, having some bad cytogenetics. And once you get a few of those points, you have up to a 30% chance of dying in 4 weeks from induction. Unfortunately, I don't find these scores super useful, although I do calculate them. It's more just a gestalt. I mean, you know which patients you think you can give it to or not. It's just something to keep in mind when determining fitness for induction for AML. Next slide. So AML consolidation. Not many options so are driven by data, but really you give a patient 7+3 induction therapy or any other form of induction therapy, they will, without a doubt, I think Bernie can agree with me on this one, they will without a doubt relapse, okay, even if they're in remission. So we don't want our patients relapsing. So once they're in remission, we want to consolidate them with something. And the way that you can consolidate them, it's either high-dose cytarabine, add that FLT3 inhibitor if they have a FLT3 mutation, allogeneic stem cell transplantation, and then there's something called oral azacitidine. Please to God, never do this. That's a whole different study to discuss in the future on this program. So it's really just high-dose cytarabine and allogeneic transplant. And this is going to be important when we discuss this randomized study with Vyxeos. And how do we determine who gets allogeneic transplant versus high-dose ARC? Bernie, can you hit next a few times? Good. Basically, if they're favorable risk, which you don't have to memorize for this point, there's favorable risk AML and there's adverse risk. If they're favorable risk, they get high-dose ARC. We know they need some. We don't know how much, but they better get some. Because if you're not giving them some, you're denying them appropriate therapy. And for adverse risk, I write allogeneic transplant if they're a candidate for such, but we still want to give them ARC also too if they're not a candidate for allogeneic transplant. But basically, that's kind of how we decide to maximize survival in our patients. They need one of these things, okay? And not giving one of these things would be, of course, inappropriate care. Next slide. All right, I'm gonna let Bernie talk about the key drug that is in the clinical study that we are discussing, the sexy drug Vyxeos, with that magical liposomal delivery system. We all love liposomal delivery systems. Actually, whenever you read a randomized study or any study on a liposomal formulation of a drug, red flags should usually go off in your head, okay?
Well, let's talk about some of the theoretical advantages of Vyxeos and why it could be potentially an option for these patients. So CPX 351 or Vyxeos is a liposomal encapsulation of both daunorubicin and cytarabine, the two drugs that are in standard 7+3 chemotherapy. But what's unique about Vyxeos is they are combined in a specific 5-to-1 molar ratio, which there was an in vitro study that showed that this ratio was the most synergistic in vitro. It doesn't mean that other ratios aren't synergistic or other ratios are antagonistic. It just meant that this ratio was the best. And when you give standard 7+3 chemotherapy and you give your 3 days of anthracycline and then the continuous infusion of cytarabine, you don't maintain that nice 5-to-1 synergistic ratio. The other theoretical advantage is it increases delivery to the bone marrow rather than other tissues. So perhaps sparing other tissues like mucositis and other GI toxicities. The downside of that potentially is if you have more delivery to the bone marrow, you possibly will have more cytopenias, little foreshadowing there. The other reported benefit is that if a drug is liposomally encapsulated, it won't be PGP effluxed. However, if you think about the way that liposomes work, they fuse to the membrane and release their internal components into the leukemic cells, upon which they can be actively effluxed. So I think that preclinical argument is a little bit BS. It also has an extended half-life, and so it can be given not as a continuous infusion, but just on days 1, 3, and 5 in induction, and on days 1 and 3 in consolidation as a short infusion. So now I'll turn it back over to Aaron to kind of set the stage for, now that we know a little bit about what Vyxeos is and sort of the rationale for using it in these patients, what should we look at when we're evaluating the trial?
Yeah, and anyone, even in the audience, these are some key questions I ask, but feel free to ask. And this is kind of, I'm not a man of statistics. That stuff's confusing, but like you can, with knowing some very simple facts or questions, you can really get a lot out of a clinical study and see if it's like, if they're trying to game the system or they're not really doing what needs to be done. So these are the things I always ask before I read a clinical study, such as the one we're about to discuss. Is the question being asked something that matters to my patients? This is really the most important one, and it's the easiest to remember because only two things matter to your patients. Even if they don't realize it, they might want that cancer smaller on the scan. They might want that M protein undetectable. But what actually matters to them is living longer and feeling better. They may think those other things correlate with that. Those are called surrogates. But as Chris and many people have shown quite definitively now, most surrogates are actually rather poor and not great markers for what matters. So, if the clinical study asks for overall survival and health-rated quality of life, ideally both, we're asking a good question. Now, I'm not dismissing all other endpoints, and they have their place. But once you start getting away from these endpoints, you need to start being even a little bit more critical of the results. So that's the first question we ask. The next one I ask is, which should seem obvious if we're like, have IRBs and are ethical about this, is the control arm what I would offer patients currently in the country I practice. And I recognize different countries have different standards and access. So I'm looking at this from an American or United States-centric mind. But, if the control arm is not what I would be giving to my patients presently in the clinic, then I just rip up that study and don't even bother reading it. I don't care if the drug's better than what I don't use. I care if it's better than what I do use, okay? So that's a real simple one. The next one's a little bit harder, but do patients get appropriate post-protocol therapy? And this really relies more on in settings where pharmaceuticals or investigators are trying to move up already approved drugs to an earlier setting. So like a classic example, like if they use, a PD-1 blockade in lung cancer in the relapse setting, we know it prolongs survival. I think it does. Don't quote me on that. I believe it does. And we want to move it to the frontline setting with chemotherapy. And they say it does prolong survival with chemotherapy versus chemotherapy alone. We better make sure that that control arm gets the PD-1 blockade at the back end, because that's what they would be getting in real life. And if they're not, then that's kind of fixing it a little bit towards the intervention. So again, if they're trying to move a drug up and it's already given in the relapse state, they better be getting that in the relapse space. And a lot of these studies, unfortunately, don't report post-protocol therapy. So you're left up to yourself to guess whether they got it. And something that we need to work on as a group, and CSO is an advocate for a good reporting of post-protocol therapy and appropriate post-protocol therapy. And then finally, is toxicity, appropriately and transparently reported? Okay, next slide. Okay,
All
I'll
right.
let you go.
Yeah, so now I'm going to give all of us the facts. I'm going to present the data, and then we're all going to think about, are these questions answered appropriately based on what Aaron had presented previously? So let's look at the pivotal phase 3 trial that led to the approval of this drug Vyxeos for patients with secondary AML. So these were patients that were aged 60 to 75, and they were fit patients. They had a good ECOG performance status. They were fit enough for 7+3 chemotherapy. These patients had untreated secondary AML. Now, we just presented a whole bunch of different definitions of secondary AML. For this study, it was either therapy-related AML or AML with antecedent hematologic disorders, either prior MDS or CMML, or they could have had AML with MDS-related cytogenetic abnormalities. So those patients that had morphology, dysplasia on morphology, those patients were not in this study. So this is just AML MRC by cytogenetic abnormalities, prior antecedent hematologic disorders, or therapy-related AML. And they randomized them 1-to-1 to receive Vyxeos or 7+3 chemotherapy with daunorubicin 60 milligrams per meter squared. It's maybe important to note. And then in consolidation for these patients, they gave either Vyxeos for up to 2 cycles or 5+2 consolidation for up to 2 cycles. And this was an open label study. The primary endpoint here was overall survival. So I want you to make that clear. It was overall survival was the primary endpoint. What do the baseline characteristics look like? When we look at the type of patients that were enrolled in this study, these were very young. They were older AML patients, but when we think about where that is in the spectrum, the median age here was around 68 years of age, and most of these patients were less than 70. So we're not really talking about the patients that are and they're 75, 80 years of age, patients who wouldn't tolerate 7+3 chemotherapy. They're not really in this study. We see that they were mostly Caucasian, and almost all patients had an ECOG performance status of 0 or 1. One of the things that I always look at in these baseline characteristics is there difference between the groups? Are there some unmeasured or unbalances between the two groups that just happen by random chance and might influence your interpretation? These groups were pretty well balanced. I would say the only thing to possibly note is there was a higher proportion of patients who had an ECOG performance status of 2 in the 7+3 arm, more prior hypomethylating agent exposure when they had their prior MDS, and then a higher proportion, just slightly numerically, of unfavorable cytogenetics also in the 7+3 arm. Now, what did we see in this randomized trial? Well, they saw that the use of Vyxeos compared to 7+3 led to a higher CR or CRI rate. That's in the bar graph on the left. So the CR/CRI rate was 47.7% with Vyxeos, and it was around 34% with 7+3 chemotherapy. And this translated into an overall survival, a median overall survival of 9.6 months with Vyxeos compared to around 6 months with 7+3. So it was about a 3.5-month improvement in median overall survival. Now, the next piece to look at is the toxicity profile. And this is where I think it's a little challenging to interpret when you read this study. If you look at the figure, what I'm looking for is a nice chart showing the rates of toxicities, both low grade and high grade, because both of those are very important for patients. This is not how they described it. They give a bar graph where you can't even see the numbers comparing the side effect profile between the two agents. So you have to kind of dig in the supplement in some ASH and ASCO abstracts to get some of these numbers. They also lumped together both induction therapy and consolidation therapy when we're talking about toxicities. In an AML therapy, the toxicities that we see in induction are often different than we see in consolidation therapy. And so that's important to note. The other thing that they did here is they normalized toxicities based on time on therapy. And because the Vyxeos patients had a longer time on therapy, some of which was consolidation when toxicities are lower in general. They took the amount of toxicities and divided by time on therapy to get a patient year number. So what did they find? They found that hemorrhage was higher. Any grade hemorrhage was higher in patients receiving Vyxeos than 7+3. Rates of febrile neutropenia were similar. However, they're high in both arms. Rash was higher in the Vyxeos arm, but some of the GI toxicities were actually lower with Vyxeos than we saw with 7+3 chemotherapy. Other key findings, there was a higher rate of infections leading to mortality in the Vyxeos group at 7.2% compared to 2.6%. And then lastly, I think one of the most important pieces whenever we're giving a leukemia therapy is how cytopenic is my patient going to be when they get this therapy? How much is this therapy going to wipe out their blood counts and lead to things like bleeding and infection-related complications? The median time to ANC recovery and platelet recovery were significantly longer with the Vyxeos arm, with a median time to ANC recovery of 35 days, which is about 2 weeks longer than what we see when we give standard 7+3 chemotherapy. And this is just for patients who achieve a CR. And all those patients who achieve a CRI or who don't respond, you're looking at months and months of cytopenia secondary to this agent. All right, so that's the data just presented very briefly. Aaron, take us away.
Yeah, so that's the data in a largely unbiased fashion, I thought. Those are the facts. And with those facts, the FDA approved Vyxeos in the United States, and then NCCN, our favorite. I'm allowed to make fun of NCCN because I sit on the panel for not AML, but for another panel. And we largely just kind of put our brains together and make up stuff. But they put, if you look, so for secondary AML, Vyxeos, CPX351, category 1 for those over the age of 60. So that is what they are telling you to do if fit. And then it's a category 2B for under 60. I suspect they did that because in the clinical study, you had to be over the age of 60 to enroll in the clinical study. So they changed it to a 2B. So there you go. If you read the paper, you look at the guideline, that is now the standard in the United States. But let's take this further. Let's CSO this paper. Okay, let's do what needs to be done and approach from these very simple questions. So the first one is this question being asked, something that matters to patients. And as Bernie stated, right, what was the endpoint of this study?
Median overall survival.
And was it improved with CPX351?
It was.
And here I am about to criticize this RCT, a large randomized study in a difficult to treat population with improvement overall survival. And we're not done. We're saying there might be more. So let's look at the second question. Is the control arm what I would offer my patients currently? So we'll have Bernie and Manju. So how would you treat a control arm in this study, okay, who was fit for induction? What would you give Manju?
So, if in the current situation, we are looking at secondary ML, and even when this particular study came out, I think hypomethylating agents, even if you didn't have the venetoclax available and there was not good enough data, I think given the secondary ML, knowing that they don't respond so well to the 3+7 chemotherapy, I think our option would be to use a hypomethylating agent. And, if there was venetoclax, then in that case, adding venetoclax. 7.3 is a difficult proposition, especially in our setting. And when we know that we are not going to get good enough responses, it's not a great option to use.
Okay. And then Bernie, what would you be recommending or assisting with the recommendations for someone who was in a control arm at the time the study was done and now? How would you treat those patients?
Yeah, I think back then, technically 7+3 would have been an appropriate option for induction. I think the consolidation we can talk about, but we were actually in this study at the University of Michigan and we enrolled patients in it. And so it really made us think, is this the right control arm for our patients, 7+3? It made us kind of go back and assess, is this the right therapy for these patients? Because I think Manju put it correctly. These patients with standard chemotherapy have quite poor outcomes. And really the goal is to get these patients to a stem cell transplant. And so we actually looked back at the data at this time and saw that both hypomethylating agent-based approaches, but also regimens like FLAG and CLAG have been studied as non-anthracycline alternatives and had 50 to 60% response rates. and sort of rivaled what we were seeing with Vyxeos at the time. So if we had a very, very fit patient and we wanted to get them to transplant, we would actually give those patients flag or clag in that setting. But if they were a little bit more unfit, I think hypomethylating agents would be an appropriate option. And I think nowadays, hypomethylating agents plus venetoclax, those outcomes greatly rival this study. And so possibly now makes this control arm a little bit more obsolete, looking at it in context several years later.
Yes, but for all sake purpose, 7+3 at the time and even now is someone fit is actually still appropriate, correct? Can we all agree on that?
Yep,
Yeah.
induction, appropriate. Now the Dono 60, maybe for the younger 60 to 65-year-olds who are rock stars, super fit, I would argue it's potential you could give them 90, although these patients all have very adverse risk cytogenetics, so that's not something to really pick on.
Yeah. So the 60 versus 90 is a whole nother episode discussion. But now I think the next question, or part of the control, really kind of blends in with the control arm, was appropriate post-protocol therapy given, or what would someone who achieves a remission with 7+3, in my practice, if they got 7+3, they sure as hell wouldn't get 5+2, okay? Which is what they mandated in the study. We know from numerous prior studies that the standard would be high-dose Ara-C or to allogeneic transplant. Now, I recognize for many reasons some patients can't go on to allogeneic transplant. So if they're not going to go on to allogeneic transplant, which if they achieve remission, they really should be if they're in this group, they better be getting high-dose Ara-C. I mean, am I wrong on this? Who gives 5+2 high-dose Ara-C? There is randomized study, prolonged survival. That is the standard. And you can cure, not a lot of these patients, but you can cure some of these patients. Definitely more than with 5+2, which is largely made up. I don't know, Bernie and Manju, have anything to add on that? I think that's the crux of part of the study where I think it all kind of falls apart.
Yeah, I think this is the biggest issue, is the type of consolidation that they did in this trial doesn't reflect. And I guess you have to ask yourself, is this my standard of care for my patients? Do I believe 5+2 to be an appropriate standard of care? It is technically listed in the NCCN guidelines, or it was at the time. I don't know if it is. I don't think it is anymore. But it was technically appropriate. Now, the problem is the data is pretty messy in this setting. We had the Mayer New England Journal 1994 study that compared very high doses of cytarabine, 3 grams per meter squared, to 400 milligrams per meter squared, or 500 milligrams per meter squared, or 100 milligrams per meter squared. So we had low doses compared to very, very high doses. And the 3 gram per meter squared arm had better survival, but this was restricted to younger, fitter patients. And so there isn't really great data on what to do in older patients. There have been a number of studies out of Europe showing that you can successfully give high-dose cytarabine consolidation by just simply reducing the dose to either 2 grams per meter squared, 1.5 grams per meter squared, or 1 gram per meter squared, depending on how old or unfit the patients are. And some of these studies show very good outcomes. And in fact, if you look at other prospective studies looking at older patients in AML, if you look at Quantum First, if you looked at other AML studies out of Europe, including the AML SG1610 study of midostaurin in older patients with FLT3 positive AML, all of these studies, these large randomized trials, give HiDAC in consolidation. They dose reduce it for older patients, but they don't just say, no, we're not going to give any HiDAC. We're just going to move on to 5+2. So there's really no data saying 5+2 is a great consolidation for these patients, but I will acknowledge the data is very messy.
I mean, remember, I asked yourself, what do you do in your practice for someone who achieves CR to 7+3 if they're in this? I mean, does anyone give 5+2? I don't know anyone that's doing that. So right away, they're not doing what we do. And you have to then really question the results. And why would they do that? Was there, I mean, so you, and then I guess, the next, it moves us on to, in my opinion, a subpar consolidation beneath the standards of what I would be practicing. Did they get appropriate protocol therapy? What did these patients get afterwards? Now, Bernie, did they comment on that, or what's the deal with that?
They don't really discuss post-protocol induction. I think or post-protocol reinduction strategies, but they do discuss the transplant rates. And there is a lot of focus on outcomes in patients who go to transplant in both arms. And one of the claims is that if you get Vyxeos, your post-transplant outcomes are better. But the problem with that type of analysis, where you don't control for assessing that upfront, is you end up getting different patients who go to transplant in both arms. And in the 7+3 arm, about 40% of patients who went to transplant with active disease. And the rate was about half of that or less. And so if you're just saying, okay, patients who went to transplant in both arms, they did better on Vyxeos. Therefore, Vyxeos leads to better post-transplant outcomes. That reflects the type of patients that made it to transplant in both groups. Now, you were able to get patients in remission at a higher rate with Vyxeos, but with the patient who got 7+3, couldn't you have done reinduction with something like FLAG or a hypomethylating agent-based approach and taken them to transplant with not active disease and seen a possibly better outcome? I think that is one issue with a study like this.
Yeah, and then finally, just because now we're starting to, I don't want to eat away everyone's time here. Is toxicity appropriately or transparently reported? I think you alluded to some of this also when you discussed the data.
Yeah, I sort of jumped the gun on this, but I really think in this study there was some medical writing, I think, going on in the reporting of the results of this study, and it's really hard to find the raw numbers. They give you a bar graph that is very hard to interpret, and then they say in the study that toxicities were similar between the two arms, or when we control for time on therapy, toxicity was similar. And patients were on therapy longer with Vyxeos because they were cytopenic for 40 days, and then received consolidation therapy. But the way that you should assess toxicities in a leukemia trial is, when I give induction A versus induction B, what are the toxicities that I see in induction? How many patients are going to the ICU? How many patients are having grade 3, 4, 5 toxicities? Break them down between the two arms. How many are having low-grade toxicities? That's crucial. And then in consolidation, what do those toxicities look like? Simply lumping everything together into one big number really hides what we see in clinical practice when we give this agent, where we see months and months of neutropenia, which we know leads to toxicities in these patients. And I think the final piece that's missing, that I think is disappointing and we'd like to see from a common sense oncology perspective, is which regimen leads to better quality of life in these patients. Is something like Vyxeos leading to better quality of life and better patient-reported outcomes, compared to something like a hypomethylating-based approach, where you could potentially treat patients on an outpatient basis with secondary AML, when we know their long-term outcomes are going to look more poor. And so I think that is a piece that's really lacking in this data set.
Yeah, and just some of the comments. I see Dr. Sandoval here. He brings up a good point. Now, he says, we're looking now, if you look at the subgroups of that paper, which, yes, we shouldn't make decisions based off subgroups, but you can then design further studies. But what it showed, if you look at the subgroups, was that in the majority of these patients, I believe we are now giving Vyxeos to, basically prior MDS who already got a hypomethylating agent, or CMML, that horrid disease. Vyxeos was no better than 7+3. And it's even worse now.
Yeah.
These patients with MDS, a lot of them, off-label for better or worse, are, especially with high blast count, are getting Ven-Aza or something of that nature, and then going to Vyxeos. So, and there was no benefit in those groups. So I think from the study, there was some benefit by the way they designed the study. It wasn't a huge benefit, but there was in survival, with substandard, at least, consolidation, in my opinion. And then many groups that we were using this in now, there was actually no benefit at all. And then there is more prolonged cytopenias dealing with that. And then the final thing is, 7+3 is pennies. Vyxeos, I don't forget that I last looked up that it must be adding that layer of fat around the chemo, adds some mega cost. It's very it's not a cheap drug. It's tens of $20s of thousands of dollars.
If your BSA is over 2 and you need more than one induction, which I guess to go on to the next slide, where I've compiled some data, about a third of patients required 2 inductions. So you're looking at a cost of up to $120,000 if you have a BSA above 2, which a lot of patients here in Michigan have BSAs above 2. That's a lot of money for, I think, a very small benefit compared to what I think is a substandard standard of care strategy. The other thing, whenever I'm assessing these trials, is what are my alternatives? If 7+3 isn't my main go-to or my main comparator. What do other outcomes look like? And what's interesting is the CR/CRI rates here are lower than almost every other data set where they've looked at 7+3 in secondary AML patients. And so I think that is a little bit intriguing. There was some dropout in patients assigned to the 7+3 arm, possibly because they saw the comparator and said, okay, I don't really want 7+3 with 5+2 consolidation, so I'm going to drop out of the study. But if you look at regimens like CLAG and FLAG, and this is something where, as pharmacists, we led a multi-center study comparing outcomes with Vyxeos compared to that regimen. This was an observational study across the US. We saw better CR rates with FLAG or CLAG, at least they were non-inferior, but they're actually numerically higher, and significantly less toxicity with that approach, and a survival time that was rivaling what we see in these Vyxeos studies. And I think Manju put it really nicely earlier. Even if you give hypomethylating agents based alone, depending on the agent, you're looking at 9 months to about a year of survival, which seems agnostic of cytogenetic risk, except for maybe P53. And so perhaps in these secondary AML patients, you can achieve just as good outcomes with a hypomethylating agent-based approach with much less toxicity than we see with an agent like Vyxeos. And so that's why, we were using it in our practice.
Yeah, I will say currently, and granted, this study was done before we were really widely using Ven HMA. It wasn't approved yet. It's very hard pressed that I'm taking an older individual, 60 to 75, with secondary AML, which is enriched for horrific cytogenetic abnormalities, TP53s. It's very unusual that I'm giving them as any form of intensive induction therapy in this era. And I don't know if other colleagues disagree or not. Yeah, we don't have the randomized study. But this is where I use the rule if it were me. And if I were that age with bad cytogenetics, I wouldn't want a month in the hospital, if not longer, getting intensive induction therapy. I think, yeah, so let's just kind of summarize it all. The primary, so there was some good to the study, some bad. And I'm not saying, this is not a slam dunk, no one used Vyxeos or not. What we're trying to show is that there might just be more than just the simple NCCN recommendation that we should give it to everyone and it's a home run. So the primary endpoint was patient-centered. People want to live longer. The control arm was suboptimal. Again, there's some, some people disagree on that. I saw some comment that they use 5+2 as if they're waiting for allo. But what I was trying to say is most people who are not going to allo will not get 5+2. They'll still get high dose Ara-C, perhaps at a slightly lower dose if they're older. The standard of care since this approval has changed in this group, again, largely to venetoclax and azacitidine. Adverse events reporting was not optimal. The stuff that really matters, they kind of skirted their way around reporting that stuff. And then, unfortunately, something that really needs to be demanded, and we have complete control over this as investigators, even if we don't design the study, right? If a pharmaceutical with $1 gazillion wants me to run the randomized study, they can put in some assessment of quality of life in these studies. And if they say no, I can say, well, then I'm not opening up your study. So if enough of us did that, I think that's quite a simple fix. I always hear the argument someone else will open the study. That might be the case, but I think with movements like CSO and kind of getting these things, we do have that power. The studies only enroll with us enrolling our patients. So we should demand assessments of patient quality of life, because that's something that's super important. Because, yeah, maybe they live a month longer, but their life's miserable. That might change a patient's decision on using a drug like this. So I think we covered Vyxeos is like Voldemort. I agree. That is a great comparison. Come on, Bernie, tell your so Bernie, for those who don't know, and I'm not condoning alcohol use. It's not good for you. It causes cancer, but use in moderation. Bernie brews beer, and Bernie brewed a batch one time that was, can you tell us about that batch?
Sure. So it was my very first beer, and it was during COVID, so some of the ingredients weren't ideal, but it had a lot of hype and it had good intentions. Just like this study that was powered for overall survival, right? They assessed overall survival, but I didn't go through the right methods. I didn't use the right consolidation in my beer making process, and it was pretty terrible. So I named it Vyxeos.
So Bernie's first beer was Vyxeos, but and were medical writers? I forget. Were medical writers used? I'm sure they were.
Yes, they were. They also did the statistics of the study, which I think is where you get the very strange and they say. There was a lower rate of adverse effects per patient year, where they try to take the adverse effects and spin it in a way where it's lower. But when you look at each induction cycle or overall, it's not lower. The only way that it's lower is if you divide by number of days on therapy and you make the days on therapy of the one agent huge. Okay, now your number looks lower. So I think that is a huge flaw.
In this medical writer stuff, and I'm not these aren't original thoughts. Other people have discussed this. Like, you know, companies design study, they design everything. Yeah, you enroll the patients. At the very least, write your own paper. And I think we need to kind of call that stuff out. I mean, in what world can you like be first author or whatever, and like have someone else who has clearly a conflict write the paper for you? And they do. They put a lot of spin on that. I think journals should be more critical of that. They're clearly not. So I think us as physicians, students, and trainees need to be critical of that. So hopefully we change from this practice. We shouldn't be using medical writers for the majority of the stuff we do. I think, what time is it? I think we got kind of covered everything. I don't know if I missed any questions. Anyone disagrees with us, we're always open to lively debate. But we hope we use this example, something that you can use as a framework when you read other studies and use these principles. And again, this was done in AML because I do blood cancer and so does Bernie and Manju, but there will be future episodes on breast cancer, lung, colon, all the good stuff where we'll go through pivotal studies. So on top of about learning of standards of care, we hope in the process you'll learn to be a better appraiser of the literature.
And I really
appreciate everyone coming. Thank you.
The comments were fantastic too. I agree with everyone's comments. Those are great points, and I love the discussion. And hopefully we can have more of these.
Thanks everyone. This has been super helpful. Manju, do you have any comments before we maybe open the floor?
No, I just wanted people to, I'm sure there are some trainees, and they're trying to look at not only just these principles, but I think we do need to think through that, what we gained by this therapy. Imagine that they all receive 4 such courses, each lasting for 35 to 40 days, and then the overall survival was around 9 months. So imagine almost 5 months out of your 9 months you've spent in hospital, and this is not an easy therapy. It's not delivered on an outpatient basis, and they all had toxicity. So we do need to think in terms of the time, whether it's well spent, and whether we have therapies which can give you a better outcome and little easy on patients rather than going through this kind of treatment. The other, question which everyone raised, and I think just to give it perspective, and I think Dr. Chirag put it very correctly, that, if we need to bring in these kind of therapies in countries like ours, where the MDRs are a main challenge, and if you are going to remain neutropenic for 35 days, it's not going to be easy. It's not going to be easy, and there is going to be a lot more, treatment-related mortality. And the last point from my side that, you kept giving anthracyclines after anthracyclines to these patients who are elderly and you're worried about cardiac toxicity. So it may be, though they reported cardiac toxicity, but we do need to think of, these patients who are going to get into some kind of infection, sepsis-related cardiomyopathy, and you have far too many doses of anthracyclines which are coming in. So these are just some of the points from my side.
Yeah, you bring up a good point. Like, why do we treat leukemia? Because patients die of having low blood counts. So if we remove their bone marrow of leukemia cells, but they have low blood counts for the next 2 months, we haven't done them any good. I actually see this sometimes happen with Ven-HMA, which is why in the field of leukemia, some of these new endpoints being used, like morphologic leukemia-free state, even CRI, like those are not great endpoints, right? Our goal of therapy is to restore hematopoiesis. And if we replace blast with an empty bone marrow, we have not helped anyone. So things to keep in mind when interpreting this type of literature.
Thanks, guys. We have a few minutes. If there's any other questions, people feel free just to speak out. We're thrilled that everyone could join for this first Common Sense Oncology Journal Club. I guess just a couple comments while we wait to see if there's any other remaining questions or comments from the group. The idea here behind this group is that we want to help all of us recognize strong studies from weaker studies. We also don't want to just be critics. And so you'll get the nuances here. Bernie and Manju and Aaron chose this paper for a reason, because there's some things here that were done very well, and there were some things here that perhaps are challenging. And so what we wanted to do, one of the reasons behind launching the Common Sense Oncology movement was to create a space for people to talk about these things. So we move away from simple hype and cheerleading, and we can start having honest discussions. And we're not just critics. We actually work towards solutions and making things better. And we celebrate and identify those trials and studies that are very well done. And we advocate for those therapies for our patients worldwide. But then we're also willing to call out problems. But more than just calling out problems, we want to do something about it. And so that's why Bernie and Manju and Aaron want to launch this session. And we're going to continue with these journal clubs to help raise awareness of critical appraisal. And then ultimately, the next generation are going to be the investigators that design these trials, put patients on these trials, interpret them, and write guidelines. And so we're hoping that this ethos of common sense principles can translate into actionable change across the spectrum of evidence generation, interpretation, and communication. So with that, I'll see if Bernie, Manju, or Aaron have any closing questions or comments, and just looking here to see if there's any other questions in the chat.
No, and as Chris said, like, we want all of you to be involved. Reach out to any of us. We have lots of opportunities, and the whole point of this is that anyone can help. You don't even need to be a physician. You can be anything, including we have patients involved in this movement, and the more people, the better. And that's our goal.
Looks like Dave, do you have a question?
Yeah, as just first of all, thanks very much, guys. I've been waiting a long time for people as smart as you guys to come across with a movement like this. It's great. I can't keep up with all literature and sort of walking through the stats and everything the way you guys do. I listen to your Wolverine and everything, and I follow you, Aaron. It's great. So not much more of a question, just like kind of keep it up. I love hearing all this. Practical ways of how to talk to patients, because I'm a transplanter in Newfoundland and Canada, way on the other side of the world for most of you guys. Most people don't even know where Newfoundland is. But this is it's lovely to hear all this. I mean, you see all these like phase 2s and low population studies and people coming around and people knocking on your door trying to get you to buy these things and put them on the formulary. And it's really great to hear some very practical ways of looking at these studies, and keep it up is all I have to say.
Thanks, Dave. Really appreciate those comments. I mean, I think you've hit on a few key points, which is the issues that we care about resonate with all doctors and patients and clinicians worldwide, which is really seeing, the big picture of cancer care, why we went into this field to help people live longer and better. And just a plug for Dave's home province, Newfoundland. I've had the privilege of speaking there and touring around. It's one of the most beautiful places in the world. And I do want to highlight that one of the key quotes of Common Sense Oncology history will be Aaron Goodman declaring himself as, "I am not a man of statistics." And that's going to go down in legend and likely that could even be the title of the future Netflix documentary about Common Sense Oncology.
I'm very honest. I mean, I know some statistics, but it's not my strength. And I think that's the some very basic principles, and you can understand more than the KOLs who are presenting these at ASCO. I kid you not. And we'll go over in later sessions, crossover and some of these other things. And it's not rocket science, and we just need to do a better job teaching it. And that's all of our responsibility.
Yeah, thanks. Manish, over to you. Question or comment?
Well, the comment is that more and more when we are looking at expensive drugs, especially when the control arm is slightly suspect, as was pointed out over here, the point is, in terms of quality of life and longevity of life gains, I think we need to, by way of solutions, invest a little more time on health economics outcome research in terms of finding out in actual metrics what is it that the bang for the buck is taking place, and not have estimates as KOLs, because they can be subjective and they can be just as much critiqued from the other end. Industry and big pharma already do that. And if they're going to be doing that, academia should be really pulling up their socks more and investing time by way of education and research in the future. It's not germane just to leukemia, it's across the board.
I agree. Thanks, Manish, for those comments. I mean, I think really, part of this is, we need to take responsibility as the community for some of these problems. We've in some ways allowed these things to happen. And so that's one of the goals of, talking about this, is allowing all stakeholders in the kind of the cancer care and research ecosystem to speak out and ensure that we move things back to, what really matters and where we can make a difference in the lives of the patients and families that we have the privilege of looking after. Bernie, Aaron, Manju, any other questions that you saw in the chat, or anyone else have a hand up?
So I think there's one question from Philip. One of the arguments I've heard for using this drug is that the prolonged myelosuppression isn't an issue, as you can take these patients to transplant in aplasia and technically they are in remission. So what are your thoughts on this?
I would point to the fact that complete remissions or MLFS outcomes are considerably worse than complete remissions with restored hematopoiesis, and also trying to get many transplant groups to take patients in aplasia to an immediate transplant is often a feat, and that does mean your patient is going to live probably in the hospital for the first 3 months of their diagnosis while you try to get them there. It is a possibility, but I think we have better options where patients don't have to stay in the hospital with cytopenias. I saw another good comment too from someone from Sweden, that they looked at their own data as well. And this is something that I don't think we do enough when we see a trial get published. I think asking ourselves, what is our standard of care? What do outcomes look like in my secondary AML patients? Do I do 5+2? If so, how do outcomes look? Or do I do HiDAC consolidation? And if so, how do my outcomes look? When we looked at our outcomes with 7+3 with HiDAC consolidation, I will tell you our survival was just as good, if not better, than what we saw in this trial. And so we also made the decision not to switch therapies. And I think looking at your own data as well can be a powerful feat when you're assessing whether or not to add a drug or not. Another question would it be the choice be different if the age group was below 50? And there have been studies looking at Vyxeos in younger patient populations. I think the data is not quite as strong. There was an AML MRC19 study that compared FLAG-IDA to Vyxeos, which showed no difference in overall survival between the two arms. There was some subgroup analyses where maybe there was a difference, but it was hard to tease out because these subgroups were very small. And as we point out, anytime you're looking at a subgroup, you have to be very careful about the interpretation of those, because you can see both false negatives and false positives from those small subgroup analyses.
Great, everyone. We're at the top of the hour, so I just want to thank our 3 expert speakers, Manju, Bernie, and Aaron. Thanks also to all of you for joining the first Common Sense Oncology Journal Club. I've seen some comments. People want more blood. We'll have myeloma probably in a few months. We're going to do breast cancer with experts from Canada, the US, Italy, and Ghana next month. We've got a GI session planned, lung and GU, and so keep in touch. Please send comments to all of us about ideas you have, how we can improve this. This really is a grassroots coalition, and I think everyone probably on the call today has now joined CSO because that's how you got the link for the Journal Club. But please help us grow this network so we can improve things and deliver outcomes that matter to our patients and families. Aaron, do you have
all these talks will be online on the website, including the slides free for all. And again, I don't know if we already have it, but there should be a suggestion for any papers that you kind of want us to do. We're always looking for ideas. Please submit those. And again, the hope is we do enough of these, a nice little bank of these things that can be used at your own institution or anywhere to discuss these papers.
Great. Thanks, everyone. Good night. Thanks for joining. Good morning. Good afternoon. Bye.